Hi, everybody. I am Susan Grant. I am symplr's Chief Clinical Officer, and really happy to be here this morning. We're going to go ahead and do some brief introductions of our esteemed panelists and then get started in talking about operations and its connection to patient outcomes. We heard some great conversations on how we can improve healthcare systems and the complexity of those systems over the last hour or so. And what I loved about those conversations is you could hear from everybody who spoke the passion around and their energy around really wanting to improve. And why is that? Well, because at the end of the day, we all know that regardless of what department or role you're in or function, we are all here to serve our patients and our communities and to really try to deliver on the outcomes that they hope for and that we strive for every single day. So with that, we have three esteemed clinicians who are very passionate about patient care and patient outcomes. And why don't we go ahead and start with Dr. Seupaul.
Hi, good morning. Tony Seupaul here. I'm an Executive Vice President and Chief Physician Executive for Carilion Clinic. We're located in Roanoke, Virginia, and we're the largest healthcare provider in the region. I'm an emergency physician by training, and I still work clinically. So a lot of what I'm hearing this morning, what we'll talk about with this panel is still exceptionally relevant. Nice to meet you all.
I'm Antrum. I am the System Chief Nursing Officer for MaineHealth in Greensboro, North Carolina. We're an integrated healthcare system and became part of Risant Health at the beginning of December.
Hi, good morning, everyone. My name is Omar Hasan. I'm the Chief Quality Officer for MaineHealth. We are a 9-hospital health system based out of the southern part of the great state of Maine.
All right, great. And I remember you said last night, Omar, I'm from MaineHealth, and it's in Maine. So thank you.
It is in Maine with an E at the end.
MaineHealth with Maine. Yes. So when we talk about operations really is the glue, and they're those processes to ensure that we have the right people with the right skills at the right time with the right tools to yield those patient outcomes that we're really trying to achieve. So Tony, as a physician executive, your world is filled with overseeing medical staff processes and different outcomes every single day. So could you talk about your experience with credentialing and its impact on patient care and how maybe technology could actually improve that?
Yes, I think that's a great question. And BJ had some great comments earlier in the session and had a great conversation last night around this particular topic and how the game has really changed around credentialing, its connection to quality and safety, and how it affects patients at the bedside. And I think for many of us, and particularly for physicians, and especially for physicians that don't get involved in med staff affairs, this is very boring stuff. No one understands it. They don't want to talk about it. And for better or for worse, prior to my position at Carilion Clinic, med staff still reports up to me. I spent time chairing our credentials committee. I was a chief of staff as well as then a chief clinical officer, where all the really bad stuff came up to in terms of investigatory requirements. And I got to really understand just how important this is as a foundational component of what we do every single day. So first, you have to be efficient, and we transitioned from a paper-based format to an electronic format, and I'm new to the symplr universe, and as I joined Carilion Clinic, I learned that we already have some of the platform that we can now extend into an electronic version. So what the key point to that is, whether it's symplr or another version, is getting your providers credentialed and privileged, both for their bedside needs as well as, of course, from the payer standpoint, which is critically important. And I think, as you all understand, if you can't do that, you're either removing or mitigating access, or even worse yet, you may have providers, as mentioned earlier, that are not privileged or credentialed and shouldn't be at the bedside, which also puts your nursing staff and others a bit in a bind. So there are efficiencies, there are opportunities to streamline and make connections across those various components. And in the last several years, I just can't emphasize how much I've learned, and hopefully in your health systems you understand the significance of what this means and how it can be an enabler for better care and better access, better quality and safety in your health systems.
Yeah, absolutely. And you said it. It's really that process could directly impact access. And when you think of our workforce shortages and how important it is to have those right people with the right skills at the right time to make sure that patients are getting what they need, that could make or break you, right? And I was also thinking when you were talking, Tony, as a staff nurse in critical care years ago, night shift, and having physicians show up to help in the middle of a patient crisis and not knowing whether or not the physician was credentialed to do what they were doing. So very critical process.
Yeah, and actually we're talking about the connection between just culture, which is something I think we all want to see in our organizations, and how something as boring, I guess, as credentialing, I don't think it's boring, but many do, as I mentioned, can impact that. Because if that nurse isn't empowered and there's a structure behind that empowerment to say, hey, let's stop the line here, let's think through this, then you've really provided a disservice to the patient, the family, and of course, to the mission of the organization.
Absolutely. And by the way, I have a question for all of our panelists, but would really like to invite you to ask questions as well. So please just raise your hand if you have a question or a comment and you want to interject. We'll be on the lookout for you. We've got microphones on either end of the... Okay, Dr. Udasi.
Thank you. Thank you so much. I'm Sharda Udasi. I'm from West Virginia, and I'm Associate Chief Quality Officer there. One of the questions that I had, again, focusing on patient outcome, earlier we were talking about nursing sort of lagging behind or reluctant to changes or adapting to new technology. When it comes to quality and safety, I feel like nurses are many times champion in that area, and for us, many times working in different organizations, it's getting the physicians engaged and having them contribute to quality and safety and think about quality and safety as part of their day-to-day work. After this many years, it's hard to achieve that. I would love to hear what thoughts the experts have on the panel related to that, and how have they overcome some of those issues. Thank you.
One of the things that I would say is oftentimes nurses are very committed to the outcomes and safety of their patients, as are really everyone who works in healthcare. But one of the things you can do is make it easy for the nurses to be able to engage with their physician colleagues, because they are passionate about it. And in my experience, our physician colleagues care very much about the experience of the nurses and the rest of the care team that they're working with. And so sometimes when some of those things are coming from people that they're directly working with, it really makes it a bit easier for them to see the benefit and the impact that it can have. You know, Tony was referencing, and Susan, a nurse being at the bedside. You know, you're in this dire situation, you need to quickly see if somebody's credentialed for what they're looking to do. And it can't be, I have to stop, I have to call somebody, I hope that somebody picks up the phone and can tell me what Dr. So-and-so is credentialed for. You know, there needs to be some type of system where that information is readily available at their fingertips. And then, like Tony said, there needs to be a culture where they're also empowered to speak up. I think sometimes in some organizations you create hierarchical structures that really deteriorate from psychological safety and someone's ability and freedom to be able to speak up. So that's what I would say related to that.
That's great.
I'll add a couple things. We always talk about quality and patient safety in the context of being a team sport, being an interprofessional activity, so it doesn't matter which part of the clinical team you belong to, or even if you are not a clinically licensed professional, if you have a contribution to make, your voice will be heard. And in order to help define the culture, we have taken steps to team up the chief medical and the chief nursing officer in each of our hospitals to co-chair the quality and safety committee. Similarly, if there's a critical care quality committee or a project-based team, we do try and pair up a doctor with a nurse or a nurse with a pharmacist so that there's an interprofessional collaboration that's built into the vehicle, the structure for the improvement work. The second point I would make is with a lot of support from our CEO and our chief operating officer, we have taken great pains to implement the principles of high reliability. So, we take it seriously. There is a preoccupation with failure, sensitivity to operations, reluctance to simplify. There's deference to expertise, and practicing resilience. But for the deference to expertise principle, we really listen closely to the person who is closest to the problem. So there's nothing more valuable than the person who identified the problem, bringing it up, and then that being factored into the discussion within the team. But we've taken pains to deliberately foster a culture where quality is a team sport. It has to be interprofessional. But you have to do it actively. It doesn't happen by default.
Yeah, and I'll just add one more point, and obviously we have several health systems. We've already heard multiple sites, multiple hospitals. Beware of fragmentation. So I learned in my organization that we have one overarching quality team, but we still have some areas across some of our hospitals where there's some nursing quality or physician quality or other quality folks that don't report up through the same structure, and I think we lose some bandwidth and there's some voltage drop across that. So that's another way, and I couldn't agree more with the alignment strategies that our panelists, my partners here, have already described.
I'm thinking when you're talking about alignment and safety and psychological safety, the safety piece, psychological safety for our clinicians is critical in terms of getting those outcomes. But it's also, when you think about our roles as clinicians, primary role is to create that sense of safety for a patient and their family. And so part of that is instilling that confidence in patients and families. So Vi, when, I know that you have, part of that is making sure that not only our clinicians are competent and credentialed, but it's also about making sure that they have what they need when they need it and the tools they need. We have a colleague here, Dee Donatelli, a nurse with symplr who is an expert in supply chain and materials management. And she often says it's about the right staff with the right stuff. And so, Vi, can you talk about, I know you have a passion about this, so can you talk about that?
Yeah, so I have the opportunity to lead the supply improvement work across our system that's really looking to more closely pair and integrate our supply chain colleagues with clinical operations. And I think that's a very important relationship. So, for example, on the nursing units, you have to work with materials management to look at your supply rooms. Are they organized the right way? Do you have outdated supplies that haven't been used in years that are taking up space and are creating clutter for people to be able to look for supplies they need quickly? Sometimes when the supply rooms aren't set up in a similar fashion, it's really hard when you're trying to share staff across different areas of the system. And so that partnership between materials management and our nursing leaders and our nursing team members is really critical to make sure that they have what they need at their fingertips to be able to take care of patients, and that extraneous supplies that they don't need aren't there to be able to distract them. It also helps us make sure that we're appropriately charging for all of the supplies that we're using, and we're keeping tabs on when we're needing to increase PAR and inventory levels and things like that. But another piece has really been a great interdisciplinary effort around physician preference items. So one of the things we weren't doing in our system is we weren't bringing physicians to the table who are using a lot of expensive supplies to be able to provide the care to the patients that they need. And we weren't sharing data and information with them. And so, you know, as soon as we did that, I'll pick on one example, our anesthesiologist, right? We were working with our ologists and our CRNAs, and we said, hey, here's the data and information on these two drugs. And as soon as they saw it, they said, wow, there's an enormous price difference between those two. We don't need to use that expensive one anymore. We'll just use the cheaper one from now on. We didn't know. And so sometimes I think just sharing information, so that's where our IT colleagues come in, because we needed their help to be able to get the information to share. That's where bringing nurses, physicians, pharmacy, bringing in people like from our supply chain, from our value analysis teams, to all be able to sit down and work together and look at those different items. We learned that for some of our items, we had physician representation on 11 different value analysis committees across our system. And so we consolidated into an enterprise physician value analysis committee that has representation from all of our proceduralists. And that was a great move for us, because what it allowed us to do is get different groups of clinicians who, in their own value analysis committee, were picking a particular product, but none of the products they were picking in their value analysis committees lined up. And what that does for us is it increases, you know, our contracting. So we have to have contracts in place with all of the different vendors. When we do that, it may mean less optimal pricing. It negates our ability to share those supplies and resources across different areas of care because the staff aren't trained and familiar with those. It means that we have to have lots of different things in place when we're looking at preference cards and things like that. So for our whole operative services team, the people in our interventional radiology and in our cath labs and in electrophysiology labs, all of those things. Metaports was one where we were using these across different multiple lines, but putting everybody together on one team and working in partnership in tandem with each other really allowed us to get down to one product, to have one contract, to, you know, be able to track cost savings, to be able to use the same product and understand if there are any safety issues, but it also decreased the amount of cognitive burden on our staff, because they didn't have to learn, oh, this person likes this particular port and wants these supplies. And this person wants this other port and these supplies. And oh, they like to do it this way. So it really allows us to be able to maximize the efficiency of our staff and our teams, and to be able to ensure a more standardized quality of care for our patients. And by the way, when you focus on providing high quality care, the dollars will follow. It does not work in reverse. If you focus on the dollars, the quality will not follow.
That's a great point. And, you know, you're highlighting the data piece, and having that data at the clinician's fingertips and kind of integrating all of those processes is a very powerful intervention.
But I think, to your point, and to your friend Dee, having that partnership with clinicians in the value analysis teams is critical. And they really help you vet products appropriately, because they have an expertise that if you're working clinically in an area you don't.
Absolutely. Great. Well, Dr. Hasan, you have done a lot of work in MaineHealth in really transforming, and getting that alignment that we were just talking about and infusing quality into operations. I know that in our big health systems now, one of the biggest challenges is that when you have multiple hospitals in a system in multiple areas across the continuum, we do have a lot of variation in care. Can you tell us a little bit about the transformation that you've created in MaineHealth?
Thank you, Susan. I think that is a great question and timely as well, because MaineHealth has been on a journey over the past decade to become progressively more integrated. We have 5 critical access hospitals. They're really far-flung, far away from the other hospitals. So it's not like a metro area where you might be able to go from one hospital to the other. And coordinating across all of those organizations has been a bit challenging. We began with the understanding that we wanted every patient across our state, across our footprint, who came to a MaineHealth facility to have the exact same quality of care and the exact same experience. And that really set the tone, and that came from the leadership at the very top, but it was embraced by the clinical leadership as well. But as you mentioned, I think this cannot happen without a measure of standardization. And I think coming to the theme of operations, we, in our organization, we believe that well-planned structures and well-designed processes result in the best outcomes. And this has been a mantra in quality for quite some time: structure plus process equals outcome, but we really have embraced that. So I think I would sum it up by saying how we design care, the design of the healthcare delivery, really determines the outcomes. We do have an abiding commitment to having the best outcomes possible. I really like what Vi had said about standardizing and having the clinician's voice in making some of those choices, although I pray we can be as successful as you have been in getting people to choose the lower cost alternative. Sometimes they don't choose the lowest cost alternative, which can be quite tricky. I think that I'm going to go back to some of the work that we've done over the years at MaineHealth, where we found that there were some teams that were doing things really well, and other teams were struggling in that same area. So part of my job was to bring those people together so that they could talk to each other. That wasn't happening before, and also learn from each other. So I will say that the quality team had a role in that, but we weren't the ones telling people what to do. We were the conveners, and then we became the coaches, and we gave people the tools to be able to learn from each other, but then also successfully implement those changes. So someone earlier in the panel before us spoke about change management, and that's really an area where my department, the quality team, excels. We really prep and prepare people, the leaders that we work with, for managing the change most effectively. But the quality is manufactured at the bedside, at the point of care, and it's designed by the people who are the managers and the care team members right there. So the role of the quality department, our identity has evolved over time. We went from reviewing the literature, finding the guidelines, working with informatics to implement those care pathways, to really being the convener and the coach and the people who empowered the frontline care teams with the tools to be able to implement those changes. And that's gone hand in hand with how we have developed our identity as a healthcare system. I think we've become more recognized for the quality of care that we provide over the years, and I think we are much more integrated today than we were 5 or 10 years ago. And I've been with the healthcare system close to 9 years now, so I've seen the journey, and it's been immensely rewarding to be able to see all of those changes happen.
So you've all talked about really just how critical it is to involve clinicians in these solutions, that they're driving the solutions. And I've always believed, as a chief nurse and being a chief nurse for the last 30 years, that our clinicians do have the solutions. It's about how do we actually facilitate their engagement and get those solutions surfaced to make them come alive. I'm curious, though, since we're talking about patient outcomes, obviously clinician engagement and driving those solutions is critical. But what about patients? And I'd ask all of you this question. How have you engaged patients and the recipients of care in your processes to improve care? I know, Dr. Hasan, you've done some very focused work.
I can start things off. So I think, first of all, we don't do that enough in healthcare delivery organizations. So I think I would love to see the patient voice represented more. What we have done is we have patient and family advisory councils in each of our hospitals, but in our mid-sized community hospitals, and particularly in our flagship teaching hospitals, we do include patients, family members, patient advocates in design sessions where we are designing care. I know that that's particularly a focus in our children's hospital, which is part of our teaching hospital, and then we do that in some other areas as well, such as joint replacement care pathway design, cardiac bypass surgery pathway design. One of the exciting things that I've seen become more accessible to us as a healthcare system in recent years has been the power of serving our patients. So we have used technology to be able to create a cohort of patients out in the community. They're not actively receiving care, or they may have received care in the past, but we can send out a survey to them with focused questions about a particular design feature in our digital health platform. So how the scheduling menu should look like. So that's been exciting. That's something I hadn't imagined as much. I trained in quality at a time when having people together in a room was the way it was done. I know that the world has changed a lot because of COVID-19. But this is particularly intriguing because so many people now have access to Wi-Fi and a smartphone that we can engage with them directly using these pulse surveys. And you can present information to patients for their feedback in a way that I wouldn't have imagined a few years ago. But that's been really rewarding and at the same time challenging to learn how to navigate.
Yeah, so great comments. I couldn't agree more. And I'll just simplify the way I think about this. We all agree that healthcare transformation is why we're here and what we need to accomplish. In order to do that, amongst the many things we want to do, be change management, et cetera, is we need stakeholder engagement. And if the patient is truly the beginning and the end of our healthcare journey, they're probably the most important stakeholder. And if they're not at the table, how then can we transform healthcare for the future? And so what you're doing at Maine, we are still, I think, a little early in our processes at Carilion Clinic, but are engaging our patient populations and families much, much more. And I think that's going to be a critical component to how we drive healthcare in the near future.
Yeah, I think exactly what you talked about, Omar, is some of those critical junction points, but then also we have a culture of safety committee at Cone Health, and we have patients, former patients, who didn't all have great experiences sitting on that committee, and we share the good, the bad, everything with them. They see all of our data, and they help us design our processes. And so, I think having them engaged and at the table and being part of the conversation is important, and there's not a replacement for their voice.
Can I just make one quick comment, Vi? Because you reminded me of something. Sometimes the greatest advocates you can find are the patients and families that are most angry with the care you provided. If you sit down with them in a room one-on-one and have a conversation and address the concerns of, you can help us get better, they want to be part of this solution. And I've seen some incredible success stories in that regard, joining our patient councils and driving change in our health system. So just a quick tip. I'm sure many of you, I see some head shaking that you've probably done this, but if you haven't, lean into those individuals that many kind of want to maybe stay away from. They can become your greatest champions.
Yeah, I would agree. And I think, next to our clinicians, patients and families know more about our operations than we do. And they can tell us very easily, where our gaps are, where we need to improve. So to pair that with clinicians and the feedback from them. It's a powerful partnership. So let me ask, I know that we have about 5 minutes left. So in the last 5 minutes, I'm going to ask the same question that BJ asked the last panel. What's one tip that you could give our colleagues here about what you've learned from how operations can impact patient outcomes? One tip.
I'll dive in. I think as a clinician leader in my organization, my tip is communication and understanding. So many of our providers can't make the connections behind the check the box operational things that we need to do, and specifically around credentialing and privileging. But once they understand that, it changes. And so our conversations around just culture, empowerment at the bedside, what it means for our patients and our mission becomes crystal clear. And I think that gives people the why and the how, and it really then supercharges the processes on both ends, both the operational end and then at the bedside, which I think is a really powerful thing to see in be it in a clinic, in the inpatient setting, et cetera. But that for me is the biggest challenge in my health system and something I'm committed to improving. And I think we're starting to see some real change there.
Yeah, I think I would say be curious about everyone. Don't assume anything. Be curious and listen. And then also connect the dots for people, because the truth is, when you work in healthcare, everyone either directly takes care of the patients or supports those who do. And helping everybody see their role and their purpose in that really grounds and connects them to something bigger than themselves, which is what we're all here to do.
Fine, that's a great point. I'll build on that a little bit. Maybe 2 points, not one, but I think they're interconnected. One is, I think we have to standardize for all the reasons people have talked about. BJ mentioned, we increasingly, because of the, I don't know what to call it, but let's say workforce shortages, we have people going from one part of our healthcare system to another more than I have seen in any time in the past. And for that person who goes into a new setting, and I was a hospitalist who covered multiple hospitals at some point in my life, and it was always intimidating to go to a new hospital where you are covering a shift and you suddenly realize things are not set up the same way as they are where you spend most of your time. So we have to standardize. I think there's no other choice. But I will add a point to that, which I think Dr. Chowdhury touched on this earlier. Listen to the people doing the work. The solutions to the problem are not going to come from the chief quality officer. They're going to come from the person who has figured out a workaround and no one's helping them fix the problem because they know what the problem is. So you have to listen to those people who are involved in delivering care. And that is really operations. That's really at the heart of the design of care. So if you remember that, that would be good.
That's great. Thank you all so much. So key takeaways, teamwork, and that this is all about operations and patient outcomes. It's got to be a team sport. And partnerships and how critical those partnerships are internally, but also as we look at different technologies and leveraging technology, and stakeholder engagement, and making sure that those stakeholders include patients and their families. So thank you all so much for your insights and your wisdom. We really appreciate it. So please join me in thanking the panel.